Hello and welcome to Module 3. Today we're going to be talking about the electronic health record. And the important things about this module, the objectives that we're trying to accomplish, are to differentiate between the different records, EHR versus EMR versus PHR, identify the attributes and functions of the HR, and we're going to kind of look at the 7 levels of HIMSS integration or implementation. Describe the systems and network requirements to support effective EHR implementation. Most of those are going to be the computer systems that you've already learned about in the previous modules. And explain how the use of an EHR system can affect patient care, safety, efficiency of care practices, and outcomes. But first, an electronic medical record. A lot of times EMR and EHR are used almost simultaneously or interchangeably with each other. And the reason is because people really don't understand the differences. But the electronic medical record primarily is a computerized patient chart that is within an organization, that a defined set of caregivers can see this record of patient information. Yes, you can put data in about the patient. Yes, you can extrapolate information from the data that you put in, but it's primarily contained within a facility or an organization. The health record, and this is really part of the reason with 2009 why it was such a big deal to implement these standards, was the fact that we could now take that electronic health record across organizations. So not just within the hospital or even within the organization, but of course between organizations. That allowed for a lot better continuity of care going from admission or outpatient clinic into the hospital, through testing phases, and then back out to an outpatient clinic or to subsequent treatments after that. We also have the patient health record, the PHR, and this is the information that a patient actually has control of. A lot of times, and one of the objectives of meaningful use was that the effective use of PHRs. So your physician would have some sort of a portal that you could log into with a username and password and actually see some of your information. The challenge was that although the facilities and the organizations and the doctors would implement this technology to allow for PHR, actually getting people to use it and to log in to see their test results, to see their lab results, to see medications or history about their visit was very challenging. So even though patients now, and especially we'll talk about this a little bit later on in the course with HIPAA, now had the ability to have access to their electronic medical records and to their healthcare, they still don't do it, and trying to figure out why. They're very active, perhaps, in checking out their bank balance, but actually logging into their physician to check out their lab results, a whole different challenge. And then how do you measure a organization or a physician based upon the behavior of someone who they really don't have any control over? It's bad enough sometimes just to get patients to be compliant taking their medications or showing up for doctor appointments, much less making them log into a PHR, which is essentially theirs, and there's no reason not to do that. Then there's the computerized patient record. It's an electronic record specifically focused on just one patient and that patient's care. That is really the digitized paper chart. And what we went from paper chart to getting the CPR really did help, especially with handwriting and things like that. But that was really the precursor to going to an electronic medical record. So depending upon the complexity of the system, this computerized patient record might be a way to put data in about a patient, but actually pulling information out or having it integrate or interface with other systems, much less across organizations, is almost non-existent. So those are kind of the different types of medical records or charts that you will see or hear talked about. As far as the attributes and functions of the EHR, I really want to focus on the 7 stages of EHR implementation and adoption that have been identified. Now, this is a HIMSS-driven Health Information Management System Society, and the stages start from 0 all the way up to a level 7. But at 0, there's almost no computerization that's been installed. Back in the early 70s is really when we started to see computerized systems being adopted in healthcare, and typically it started with the ancillaries. And when I'm talking about ancillaries, we're talking about radiology, as well as laboratory, and then also pharmacy. And by the way, we're talking about zero. Nothing is installed. So stage 1 is when all 3 ancillaries are installed. I would be hard pressed to think that there are any organizations out there that you might encounter that would be at stage 1, but it certainly is a possibility. Most have at least gotten to at least a stage 2, where there's a clinical data repository, a centralized database, and there is some rudimentary, at least, clinical decision support in the aspects of alerts or recommendations based upon lab tests or radiology results, or drug interactions with drug-drug or drug condition interactions. And to have that, there has to be some sort of a controlled medical vocabulary. And that's very important for that interfacing and integration. HL7 is something that you may hear about as kind of a language, pipes and carrots. It's a lot of programming that allows for the interfacing of 2 disparate systems. But again, stage 2, then we get into stage 3, and this is kind of that clinical data repository, clinical patient repository, computerized patient record aspect of the EMR, where we're doing nursing and clinical documentation. Again, the clinical decision support with some error checking. And another part of that stage 3 is that PACS is available outside of radiology. So a lot of PACS projects were going on in the late 90s and early 2000s because you may be able to take a picture, but now we had to take that X-ray, that physical X-ray, and put it into a computerized system somehow. Well, with the advent of electronic pictures, who uses film in their cameras anymore? Now the pictures are actually coming digitized, so it's a lot easier for them to be put into the system, and subsequently, of course, it's a lot easier for other computers and other users to see these pictures that are generated in radiology. From there, we're going to go to stage 4, and stage 4 was really around the mid-2000s. A lot of people were still struggling with stage 4, and this is that physician order entry. A lot of organizations, including Ohio Health, one that I worked with in the mid-2000s, was still doing things on a documenting, even though the nurses were documenting through McKesson, they were still having a unit coordinator or unit clerk transcribe physician orders into the system and or fax things down to pharmacy. Well, in a true POE system, there is no faxing that's involved. The physician is presented with order sets or their own order. They'll fill out the information, hit the button, put in a password or so, and off it goes. And all of those orders are electronically delivered to the correct ancillary departments. With this physician order entry, it's a much larger scale of clinical protocols and order sets. These are evidence-based management, and a lot of the pushback coming from physicians was that they had their own diabetes order sets or their own way of doing DVT prophylaxis or to handle a CVA. So there was a little bit of pushback from physicians who had been doing these for years, but at the same time, we have these evidence-based medicine order sets that were coming out and being pushed out, and there was a lot of friction and a lot of adoption hesitation. I know we talked about adoption and change is good, you go first back in Module 1. But if we can get through that, then we get to stage 5, which is that closed-looped medication administration. From the physician ordering, and a lot of the information in the 20-year-old study to err is human was still valid even in the mid-2000s, that a physician would handwrite an order, that the handwritten order would be transcribed by a non-clinician, and then it would be faxed potentially to a pharmacist in the pharmacy, who would then have to figure out what either the physician wrote or the unit coordinator wrote, to then put it into the system, to then have it go up to the Pyxis or be sent up by pharmacy to then be administered to the patient using the 5 rights, and basically from packet to cup to mouth. Well, with closed-loop medication administration, there's a real tight coordination between the ordering of the medication, pharmacy, dispensing, the administration, and the documentation. And this is really when the bedside barcode administration came around. The funny thing is that back in the 70s, and I think it was Kroger's down in Cincinnati, was the first barcode utilized in grocery stores for inventory control. Now, the mid-70s or early 70s, mid-70s, that's 50 years ago. But for whatever reason, we were not able to take that very easy technology and push it into healthcare in order to augment patient safety. With the bedside barcode, we're basically barcoding the patient and we're barcoding the medications, which have been barcoded for inventory purposes for years. And we're making sure that the right medication is getting to the right patient at the right time, in the right dose, through the right route, all the typical, rights of the patient. And some of it includes 6 and 7 rights of the patient as well. But that whole closed-loop medication administration, from an electronic ordering to an administration that has electronic tracking and documentation, is really what stage 5 is all about. Stage 6, this is really where physician documentation with those evidence-based practice and true clinical decision support really comes into play. So that a patient is presented with a CHF, with a CVE or CVA or whatever they're presenting with, and that there is a true protocol that is followed by the physician. And if there is an exception to the protocol, that there are reasons why. And then the decision support to allow for exception reporting, variances, and compliance reporting that can then show the utilization. This stage 6 was one of the hardest, in my opinion, to attain, and a lot of organizations still have not gotten to stage 6. You probably are going to find a lot of organizations are going to be in stage 4 or stage 5 in your career. Hopefully they'll be up to stage 6. Stage 7, that's really the full EHR. And it's the ability to input, manage, share data along the whole continuum of care, and to pull that data out in information and the aspect of information, and then be able to utilize that information for clinical decisions. So again, this full EMR, full EHR across the continuum of care, multiple providers, multiple organizations, not just the one organization in which you work, are working hand in hand to share this information and make sure that it's being utilized appropriately so that the patient receives the best possible care based upon evidence-based practice. Next, and again, we talked about this, the whole implementation around effective EHR, and we'll talk more about this EHR implementation next week. But, it's absolutely the scaling of computer power and storage, the reduction of expense, and widespread broadband definitely have that in there. One of the things that I also noted was, especially back in the early to mid 90s, was that there was a lot of reticence among clinicians in adopting technology, not just physicians, but also nurses, pharmacists, lab techs, radiology, whomever. People were reticent to accept this new technology. And a lot of this had to do with age. Physicians didn't grow up where they had to type. So using the keyboard as an interface to interact with a patient's chart was just not what they did. They grew up with a pen and paper, with Xerox paper. It was little black sheets to make copies, dittos, which were machines to make copies at high rates of speed before Xerox became more prevalent and more cost efficient. But they had their pen and their paper, and they were very comfortable with that, and they hadn't interacted with computers. Going through the years, as the age of our clinicians are lowering down into their mid-30s on an average, you'll see that a lot of these younger clinicians in their 20s to mid-30s, even early 40s, grew up utilizing computers. When somebody who's 50 years old, when they were a kid and they had to do a paper or an assignment, they actually had to go to a library where they had to go to the stacks and pull out the card catalog and then find through the Dewey Decimal System the book that they wanted to, and then they would look at the book, which may be years old, to write their papers. Well, nowadays, obviously, we have grown up with computers. We use the keyboard, the mouse, video game controllers, other input devices to interact with the computer. And of course, we have a wide variety of output devices, including virtual reality now, as well as 3D printers, so that when we're interacting with these systems, we're much more comfortable as an average clinician now than the average clinician 20 years ago. One of the first barriers to doing physician order entry is teaching a physician how to type. Well, you can imagine how that goes when you have somebody who's in their 40s or 50s or 60s 20 years ago, and now they have to learn how to type. Well, that's what secretaries were for. That's what people who learned how to do that. I was a doctor. I'm a nurse. I take care of patients. I don't type. Well, we all type now. So that's no longer one of the barriers. That also goes into some of the cultural difficulties with effective EHR implementations, especially if you have a culture which is not an early adopter type of culture. We're much more comfortable doing things the way they've always been done because they work and they're fine and they're good enough, and this new stuff, well, that's just not what we do here. Well, some of that goes by the wayside as those clinicians get older, and as newer clinicians who are more apt to be open to change, who change their cell phone every couple years rather than every 10, who are definitely looking for the bigger and the best, and will accept bugs. They get an app that doesn't work. Well, a month later it'll be fixed, and then they'll play with it and work with it. So feel like the generation of the clinician or the age of the clinician also plays into the amount of patience that you have with technology. So in addition to the electronic and physical requirements, in addition to the internet or the broadband requirements, is also the organizational change requirements, and also the capacity of the clinicians to adopt change. So those are kind of the 5 that I really kind of look at when I talk about effective EHR implementation, is that you have to have the computer power, you have to have the hardware, you have to have the clinicians willing to accept and to change, and the ability to interact with that technology. So those are all the things that are important with that. And finally, the electronic health record system and how it affects patient care. Obviously, it can reduce a number of the medication errors, improve safety through that e-prescribing, through clinical decision support systems. It improves efficiency in healthcare. Not only do we have the information sharing and cost savings, but we also have a reduction in certain errors, such as duplicate lab errors or duplicate lab orders or duplicate radiology orders. I remember the time when a phlebotomist would come up, and then 6 hours later somebody else would come up and take blood, and the patient's like, why are they taking blood multiple times? Well, the system didn't catch that the order had been placed twice, or there was a tick where the order got placed once but showed up twice in the system. So, but we didn't have the controls in place to be able to prevent that from happening. So you're seeing that the care that patients are receiving is more efficient, that there's less duplication of orders, and that there is certainly a cost savings involved with that as well for the provider. Information sharing, obviously that is an impact on quality, as providers and different providers can provide and access the data and really coordinate the care for the patient with their fellow clinicians. And of course, the patient satisfaction we already mentioned, but wait times for scheduling, improved communication, and certainly turnaround times for inquiries and billing. Hopefully there's an improvement in the quality of the billing so that the billing is more accurate and there's less duplication of charges. Of course, there are it's the access of patients to their own records, the PHR, and reducing the need to provide the same information repeatedly to providers. Hopefully, once you walk into a system and you're able to provide the information, when you go into that same system for a test or for a follow-up, you don't need to provide all the information again, and certainly not on paper with pen and paper. And actually, that's still something that's an issue today, going in and providing that information. So hopefully that's something that will become a thing of the past as we move forward over the next 5 to 10 years. Outcomes. Certainly the effect of patient safety and efficiency of care and utilization of care models are patient outcomes. And because the providers have access to evidence-based protocols, these clinical protocols, order sets, care plans, because they have access to this, it's not just has your physician or clinician gotten up to date on their information, it's almost forced upon them because of the fact that the evidence-based practice is updated even without the physician or the nurses or clinician actively taking care of that. Cost savings, we talked about the reduction of duplicate tests, clinical workflows, reduction in the patient care errors, and of course, this is going to lead to a lower cost of care with the savings passed on to the customer. Now, the customer is not necessarily the patient. The customer in this situation is anybody who's actually paying the bill, and that would be private insurance as well as the government. Private pays a very small portion of the mix of the revenue mix for a hospital or for an organization. So when we're talking about saving some of this cost, there certainly should be some savings that go on for the government as well as for insurance companies. So just as a reminder, please review this lecture and the assigned articles and to-dos. Please complete the assignments and discussion by the due date. And again, thank you so much.